Welcome back, my dear students, my dear medical doctors, those who are attending this interesting recorded webinar of Professor Dr. Rajendra Raghuveer Deshpande. I am MD in Ayurvedic Medicine and MD in Ayurvedic Physiology. I have the teaching and practicing experience for last 35 years. So I welcome you all in this interesting webinar of half day, but you can enjoy this webinar because of the app, mobile app of Professor Dr. Deshpande for 1 month anywhere, anytime. You can enjoy this webinar n number of times. And definitely, I am confident that you will be master in reading the electrocardiogram or interpretation of ECG. So ECG made easy by Professor Dr. Deshpande, a fantastic webinar of approximately 3 hours. But as because of the very little amount as like a donation, you can pay 200 rupees and enjoy this recorded webinar for n number of times, anywhere, anytime, with this mobile app of Professor Dr. Deshpande, that is Ayurveda Academy. Yes, I have my own YouTube channel where I also do some what you can say the sharing of knowledge and experiences. But with this app, I'm also giving you a lot of interesting webinars and workshops and seminars and training programs. Yes, I have also an idea of digital library for the first year students, second year students, final year students, maybe third year, maybe fourth year, but you will get a digital library with nominal paying a subscription, monthly subscription, maybe little bit of 200 rupees. But you can enjoy a lot of subjects, especially the PPTs will be available, audios will be available, and videos will be also available in this digital library. So I request all of you to place this particular order through my app. And I request all of you to convey this message to as many people as you prefer, as you like, that yes, Professor Deshpande, after successful YouTube activity, he has launched the mobile app, Android app, which is also called as Ayurveda Academy. So you can go to the Google Play Store and please download the app and always search what new is coming through Dr. Deshpande. Okay. So ECG in general medical practice, reading of ECG, interpretation of ECG, part number 3. So let us start to discuss with this session, very interesting session. What we have learned in the first session, in the morning session, in the first half, first part, what we have learned in the previous session? Yes, we have learned pulse rate can be measured by physically, heart rate can be measured, but with the stethoscope, with the pulse rate, but through the ECG electrocardiogram, you can check out the heart rate. What is the heart rate? 300 divided by big squares in the waves R and R. So normally it should be around only 4 squares. So 300 by 4, it comes round about what you can say the 75 to 80 pulse rate. Left axis deviation also we have learned. So please check all these videos. Video 1, video 2, video 3. And for your benefit, I have also sharing the PPT that I am using to explain you the facts of ECG. So this PPT will be definitely useful to make of your own handwritten notes. But this everything you can repeat for n number of times in 1 month only with paying rupees 200. Okay. So right axis deviation, what is the mnemonics? Left leaves R and R in the first lead upward, R in the third lead downward. You check it first video. Then right axis deviation, only you have to check first and third lead. This webinar is interesting because Dr. Deshpande is making ECG the most simplified form. No more biophysics, all the electrical circuits, nothing. Only what we need, we should know the like a formulae of physics, formulae of chemistry, formulae of mathematics. Then the subject is very easy. So these are the mnemonics. Only check first and third leads and see the R wave, whether it is upward, whether it is a downward. Okay. In the part 2, very interesting topics, left ventricular hypertrophy because of the chronic hypertension, right ventricular hypertrophy, then right atrial hypertrophy because of the lung problem, that is P pulmonale, left atrial hypertrophy, P mitrale, problem in the mitral valve, mitral stenosis or mitral regurgitation, Then myocardial infarction, very important cardinal signs. For example, ST elevation, T depression, and yes, Q wave. Q wave size is indicating how much muscle has been necrosed by the heart attack, coronary blockages. And I have mentioned that angina pectoris, ischemia can be diagnosed only with the stress test. Resting ECG is crossed, is not useful to diagnose angina pectoris. Remember my word. Then you have to do, if it is stress test is positive, go for 2D echo. And what to look? Ejection fraction, right? It should be above 50 or minimum 50. If it is less 45 or 40, your heart is weak. WEAK. And what to do? Angiography. Because you have to find out whether one coronary artery is blocked, two arteries are blocked, three arteries are blocked, and how much blockages? One block, two block, three block, 50% blockage, 70% blockage, 90% blockage. One vessel disease, only one coronary artery, little bit blockages, then yes, you can try even allopathy and Ayurveda together. Then second degree heart block, maybe you go for angioplasty. After angiography, you do the correction of that blockages. You remove, you push the balloon and the blockages being kept aside and blood flow is going well. And three vessel disease, 90% blockages, all the coronary arteries are blocked. Then there is CABG, coronary artery bypass grafting. This can be the ultimate solution to save the patient's life and to avoid the recurrence or any more heart attacks. Okay. So this is all about the preliminary that I have introduced. Now in the third part, remaining few important points I'm going to discuss you, which are not too much important, but yes, if you know it, that is the additional feather in your cap. Heart block types. There are different. This is related with SA node, AV node, bundle of His, right bundle branch, left bundle branch, and Purkinje's fibers. Okay. Hyper and hypocalcemia. Electrolyte imbalance also can be diagnosed by ECG. These things is very interesting because if you tell these points at the time of examination, the examiner will be very much happy. Because what are the advantages of ECG? Everybody tells that I can diagnose heart attack, I can diagnose the left ventricular hypertrophy, I can diagnose the heart rate, but very few students, they explain that I can diagnose. There is supportive evidence that electrolyte imbalance, especially the calcium and the potassium. So hyper means excess and hypo means less calcium levels in the blood. Anemia means blood. Remember this thing, anemia means blood. For example, another uremia. Urea, when it is accumulated in the blood, in spite of going through the urine, kidney failure is there, and that particular unconsciousness or shock is called as a uremic shock. So what I want to tell you, anemia. Anemia is blood. Always remember. Hyper, excess, hypo, low. Kalemia means potassium. Okay. Digoxin effect. This is the best drug to treat with the what you can say the ischemic problems or the ischemic heart disease. Always Xanoxin is given to make your heart more healthy and strong. But this is very useful drug if it is not used properly. This is called as a week of medicine or Sunday of medicine. Very interesting word. Sunday off. You have to give the tablet from Monday to Saturday. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. One day off. Don't give the tablet because this tablet without break, if it is prescribed to the patient, that can cause digitalis toxicity. That is called the digoxin effect. And then very, very rare dextrocardia. In spite of the left side, the heart is on the right side. That is called as a dextrocardia. So let us start. This is first degree heart block. I am giving the formulae. This webinar is very important to get the formulae from Professor Deshpande. Long PR interval. Now, what you see here is the P, here is the R. So this PR, distance between the PR interval, normally it should be 0.12 to 0.20 seconds. But that is 3.5 dot square. So now here you can see the atrioventricular node, okay, AV node, okay. Then the first degree heart block is a problem over here. Electric current switch off or the what you can say the short circuit is over here, first degree heart block. Okay. So here you can see the P wave is over here, R wave is here, normal 0.12 to 0.20 seconds, 3 to 5, but this is more prolonged PR interval. Okay. Now, prolonged PR interval is equal to first degree heart block. This is my formula. Write it down. First degree heart block is equal to long PR interval. So, okay. So, this can be in between 3 to 5 small square. Causes ischemic heart disease, hypokalemia, there is low potassium due to the diverticulitis, then acute rheumatic myocarditis, drugs like digoxin, beta blockers, then calcium channel blockers, these all can cause the long PR interval because of the heart block. Okay. Sometimes this is asymptomatic, no specific treatment is required, not indication for a pacemaker. When it is very beginning, first degree heart block, don't get much stress. This is okay. Then we will go further. Mobitz type 1 AV block, atrioventricular block. This is progressive lengthening of PR interval. Here you can see 0.16 seconds PR interval in between this P and this R. You have to just see by the naked eye and you can immediately how many small dots, small squares are there. This is 0.28 seconds. Here it is increasing. Again 0.32 seconds. So in this, again P wave, this another segment has been started. But gradually when PR interval is increasing, that is called as a Mobitz type 1 AV block, which is also related with the atrioventricular node. Okay. Progressive lengthening. The distance is increasing of the PR interval. P wave fails to be conducted. In between, there is no P wave in between. Then PR interval reset and cycle repeats once again. Okay. So this is called as a first degree Mobitz type heart block. Okay. So non-conducted P wave. Here you can see. Here the 0.16, 0.28, 0.30, and but there you cannot get the P wave like this because the continuous PQRST complex has been lost. You understand? PQRST this complex has been lost, but again here you can see PQRST. Again PQRST. This pattern has been lost in between, and so that is called as a non-conducted P wave. Non-conducted. You are consider PQRST complex that has been lost after lengthening of this PR interval. So this is Mobitz type 1 heart block. So now we will go a little bit detail about this Mobitz type 1 atrioventricular block. One of the types of second degree heart block, also known as the Weinbach phenomena. This is the scientific name. What are the features? Progressive lengthening of PR interval. Then P wave, that means QRS complex, fails to be conducted, absent, in between absent. PR interval resets. Again, and I'm sorry, this is a printing mistake. Again, cycle repeats. Okay. Abnormal conducting to the AV node during high vagal activity. Sometimes it can happen during the sleep. In generalized disease of conducting tissues, this can happen. Benign form of AV block. This is not at all serious. Permanent pacemaker is not required. Temporary pacing before surgery is enough when this type of the heart block is there. Okay, let us move further. Mobitz type 2 AV block. Now here, PR is normal and constant. Occasional P wave fails to be conducted. You understand? 0.16, 0.16, 0.16. PR interval is the same, but PQRST complex is been lost in between. Again, this particular PQRST has been started, but in between, the one group of PQRST complex has been lost. That is because of the loss of switch current, electricity current has been damaged in between. So this is Mobitz type 2 atrioventricular block. Okay. So PR is normal and constant. Occasional P wave fails to be conducted, result from abnormal conduction below AV node. Do you understand? SA node, AV node, bundle of His. That means the problem will be in the bundle of His. More serious than type 1 heart block. Refer to the cardiologist because pacemaker may be needed. Indications for pacing, that is acute myocardial infarction or during the pre-operative management. Next, third degree heart block, more serious and more serious. Okay, P wave, that is atrial rate, is 85 per minute. Do you understand? P wave means, sorry, P wave rate means you have to measure the distance. This is the P wave and this is the P wave. So you have to measure this 1, 2, 3, etc. And you again divide 300 by this 3, and it will coming like this 300 divided by 3 or 4, and it will come around 85 per minute. Okay. QRS complex, that is ventricular rate, is, I'm sorry, ventricular rate is 54 per minute, that you can get with the RR interval. So broad QRS complex, you can see PQRS is, especially QRS complex is wide and broad. Okay, no relation between P waves and QRS complex. So there is no specific pattern. Immediately after P, you should get QRST, but this pattern has been lost. There is no QRS complex regularly coming after P wave. So there is also difference in the atrial rate. There is also difference. Atrial and the ventricular rates are separate. So this is more serious because atria are beating of its own, ventricles are beating of its own, and there is no coordination in between atria and the ventricles. That's why this third degree heart block is definitely a little bit more serious than the another thing. So you can see over here, this is the P wave, this is the P wave, again this is the P wave. These P waves are marked over here, and QRS complexes are also marked over here. This is the close-up view. So in this third degree heart block, what you can see, complete interruption of conduction between the atria and ventricles, and two, that means atria are working of their own, ventricles are working of their own. So there is no proper coordination like a physiology. Okay. So in acute inferior myocardial infarction, third degree heart block can occur, and there you have to give the pacemaker to the patient to make a rhythmicity in the conduction. Acute anterior wall myocardial infarction, third degree heart block indicates extensive infarct, and there may be poor prognosis. Prognosis means the patient cannot be cured easily, or he may die in this condition. Temporary pacing preoperatively. If due to the third degree heart block, heart failure, dizziness, loss of consciousness, permanent pacing is always indicated. Okay. P wave rate 85 per minute, that we have already seen. QRS complex is another rate, that is 54 per minute. This is 85, this is 54. There is a gross difference in the conducting the electricity, atria and ventricle. Broad QRS complexes, no relation between P waves and the QRS complexes. These are the features of third degree or complete heart block. Okay. So here you can see another variety, 2 to 1 AV block, atrioventricular block, 2 to 1. Alternate P waves fail to be conducted. Alternate P waves are not followed by QRS complexes. AV block is a special form of second degree heart block. So you can see non-conducted P wave, and here it is, this is a P wave, but in between you may lose, there is no P wave. Okay, so P wave is there, but sometimes there may not be P wave. So alternate loss of, what you can say, the P waves are lost and not followed by the QRS complex. Okay, so this is 2 to 1 AV block. Here you can see non-conducted P wave, that means QRS complex is not there, and after this P wave you can get the QRS complex. This is the close-up, so it is more easily understood. This is P wave, but there is no QRS complex. Can you see this? This is P wave. Okay, this is P wave, but there is no QRS complex. Here P wave, but QRS complex is present. Okay, so 2 to 1 AV block, alternate P waves fail to be conducted. Alternate P waves are not followed by the QRS complexes. AV block is a special form of second degree heart block. Now, left bundle branch block. There is again broad QRS complexes. QRS is less than 0.12 second, and QRS, that means this is the normal pattern, less than 3 small squares. But here QRS looks like W in V1. If you see this V1, W, this is W. So again go down and again up. So this is like a W, and here QRS looks like W in V1 and M in V6. That is called as William pattern. So these two words you should remember, that this is the W type of the pattern and this is the M type of pattern. Like we draw the M. So this is M like pattern in the V6. So this indicates left bundle branch block. Here also you will get the left axis deviation. Okay. Let us see further. QRS looks like W in V1. Go up again. And here you can see M-like structure. This is the William. W and M. Can you see William is to begin with W and end with the M. So this pattern is indicating of left bundle branch block. Let us move further. Now, BBB, bundle branch block, left bundle branch block. Broad QRS complex, this is the first criteria. QRX morphology as explained as per the text that I have mentioned to you. QRS is less than 0.2 second and QRS is less than 3.5 small squares. QRS looks like W in V1 and M in V6. Mnemonics is William. You have to remember the name William, person name W and M. W in V1, M in the V6. This indicates the left bundle branch block. And these causes are like this: ischemic heart diseases, left ventricular hypertrophy because of the hypertension or aortic stenosis, fibrosis in the conduction system like SA node, fibers are fibrosed, right bundle branch or left bundle branch. This may be asymptomatic and may do not require any treatment of their own right. If there are problems like hypertension, aortic stenosis, you have to treat IHD problem, and then automatically this bundle branch block will be under control. Okay. So let us move further. This is right bundle branch block. Here also there is a broad QRS complexes, but QRS looks like M in V1, opposite. First it was William, this is Morrow, M-O-R-R-O-W, Morrow. That means M is in the V, M1, can you see M? And here you get the W. So this is W over here and this is M over here. So this is the Morrow in right bundle branch block. Okay. So here again you can see Morrow, M is over here and again W is over here. W in V6. Now this is called as a Morrow is the mnemonics. Now we will discuss a little bit more about RBB with the revision. Broad QRS complexes, QRS morphology as explained like before. Normal QRS should be less than 0.12 second. QRS should be less than 3 dot squares, but this is not the case over here. QRS looks like M in lead V1 and W in lead V6. That is called as a Morrow mnemonics. Causes are same like the left bundle branch block, ischemic heart disease, cardiomyopathy, atrial septal defects, massive pulmonary embolism. RBB is relatively common finding in otherwise normal hearts also. Both left bundle branch block and right bundle branch block are asymptomatic by themselves and do not require treatment of their own. You have to treat the original causes, then automatically this bundle branch block problem will be under control. Okay. So now here you can see hypercalcemia. Normal QTC is 0.35 to 0.43 seconds. Now here you get the short QT interval, Q and T. Can you see? This is Q and this is T. So short QT is always indicating hypercalcemia. Okay. Next we will go further. Causes of hypercalcemia. There may be hyperparathyroidism. PTH hormone is in excess, so blood will have the more calcium. Primary or it may be the tertiary. Myeloma, that is malignancy. Medicines like thiazide diuretics, excessive vitamin D intake can cause excessive calcium in the blood, sarcoidosis and thyrotoxicosis. There may be risk of cardiac arrest with severe hypercalcemia. So you must look for the proper symptoms. There may be vomiting, there may be drowsiness, there may be plasma calcium greater than 3.5 mmol per liter, and urgent treatment is required. You can give, doctors always give in the ICU 0.9% saline, 3 to 4 liters per 24 hours, then IV furosemide 20 to 40 milligrams every 6 to 12 hours. Disodium, pamitonate, single infusion, monitor the urea and electrolyte calcium level every 12 hours. This is the management of hypercalcemia. Okay. Now, hypercalcemia, to calculate the QT interval is not very easy. This is something a little bit complicated. Duration varies with the heart rate. Faster heart rate, shorter QT. QTC is equal to QT divided by root of RR. Now, this is mathematics. QT divided by root of RR. Normal QTC is 0.35 to 0.43 seconds. Okay, so in this last figure, you can revise it by looking again and again. QT is 0.26 seconds, heart rate is 100 per minute. So QTC comes with this equation 0.34 seconds. Now, symptoms I have already mentioned, anorexia. This is important because many people they take the calcium supplements without doctor's prescription. That is very wrong. That can also cause hypercalcemia. So there may be weight loss, nausea, vomiting, abdominal pain, constipation, polydipsia, excessive thirst, polyuria like diabetes, weakness and depression, and you can get in the ECG prominent U wave also. Confirm diagnosis by doing the calcium level in the blood, that is plasma calcium level. Now, we will discuss about hypocalcemia. There is a long QT interval, opposite, long QT interval. There again you have to apply the formula. For example, long QT interval here 0.57 seconds. Heart rate is 55 per minute. QTC is 0.52 seconds. Clinical features in the practice. When there is a less calcium, peripheral and circular paresthesia, tetany will be there, spasm will be there, fits and psychiatric disturbances. Then Taussig sign will be present like carpal spasm when brachial artery is occluded with the blood pressure curve. You have to go for my clinical examination videos on the YouTube and you will get these signs, how it can be performed. Then stochastic sign, that is twitching of facial muscles, then when tapping over the facial nerves, okay? And papilloedema, it can be examined by the ophthalmologist, okay? So now about this hypocalcemia, again you have to do the blood check like plasma calcium level, not forgetting to check simultaneously albumin level as well. Causes of low calcium, that is hypoparathyroidism, PTH hormone following thyroid surgery. It may be autoimmune or it may be the congenital also. Chronic renal failure, CKD, vitamin D deficiency, drugs like calcitonin, acute pancreatitis, these all can cause the hypocalcemia. You have to give immediate calcium gluconate 10%, 10 ml. Okay, next. We will discuss further. We will discuss now hyperkalemia, that is the potassium level. Okay, hyperkalemia, tall tented T waves. Tall tented T waves. Their QT interval important. Now in the calcium, now potassium, you have to look for T wave. So increased potassium is equal to increased T wave height. Can you see over here? Here also, you can see the height of the T wave. That is very tall. Tall tented T wave is a formula for hyperkalemia. Tall tented T wave. Hyperkalemia also can be caused by, you can see the flattening and even loss of P wave, lengthening of PR interval, widening of QRS complex, and arrhythmia. So, in addition to the tall T waves, you have to remember these features of hyperkalemia, that is excessive potassium in the blood, flattening and even loss of P wave, lengthening of PR interval, widening of the QRS complex, and arrhythmia. You can confirm this your diagnosis by blood test, elevated plasma potassium level. Underlying cause may be renal failure. Complete drug history is essential in any patient with abnormal ECG. Okay. So now hypokalemia. Here you get opposite small T wave but prominent U wave. Changes which may accompany hypokalemia are first degree heart block, depression of the ST segment, prominent U wave, and clinical features will be muscle weakness and cramps. Commonest cause of hypocalcemia, potassium is diuretic, use of excessive diuretic. That's why in my olden days when we were giving injection Lasix to the cardiac edema, cardiac patient, these patients are always suffer from hypopotassium, less potassium because of the potassium is going out with the use of diuretics. Then we always use the potassium supplement, Kesol liquid. We have at that time Kesol liquid always given with the injection Lasix. But nowadays potassium sparing diuretics are available, so there is no need to give another supplement with the diuretics. Okay, so this is about the hypokalemia. Here you can see hypokalemia, that is decreased potassium level, and here you can say the height of the T wave has been decreased, small T wave, but the prominent U wave is the feature of potassium. Okay, now I am going to tell you the last but important some topic like decoxing effect. This is called as a reverse tick, that is ST depression. We do usually the tick mark like this, you know. I will just show you like this. We do the tick mark, but here the tick mark is opposite. So this is the reverse tick ST segment depression is a special feature of decoxing effect. Can you see over here? Here is effects. You can see these effects. Okay. Now next. Here specifically, we have seen on the second lead, this is the reverse tick mark, and that is ST depression is in the position of reverse tick mark. Okay. Here we have this normal tick mark, and this is the opposite or reverse tick mark. This segment is little bit on this right side, but here right side segment is little bit less. So reverse tick ST depression is a special feature of digoxin toxicity. Reduction of the T wave size, shortening of the QT interval. Then T inversion, then arrhythmia, sinus bradycardia, ventricular tachycardia. These all features is showing you the acute toxicity of digitalis. Okay. Now, the last but not least, this is maybe more times not practicably useful for you, but heart lies on the right side. What will happen? P wave will be inverted in the lead one. Can you see? P wave is inverted. Right axis deviation. What is the formula? Do you remember? Right reaches. That's correct. So this is the R wave in the first. Only you have to look first and the third lead. Right downward deflection. This is again R upward deflection. So right reaches. This is right axis deviation. Decrease in the R wave height. Can you see? Decrease in the R wave height. Then across the chest leads V1, V2, V3, you will find that this length of the R wave is little bit less in V1 to V6 leads. Okay, so this is dextrocardia. Heart lies on the right side. Decrease in the R wave height across the chest leads. Heart lies on the right side. P wave is inverted in one and right axis deviation. For location of the apex beat, do the chest X-ray. Then Cartesian syndrome will be present like dextrocardia plus bronchiectasis plus sinusitis. Together, this specific syndrome has been mentioned. No specific treatment for this type of the right side of the heart. Okay, not needed. So, my dear friends, in this interesting webinar, ECG reading made easy by Professor Dr. R. Deshpande, half-day seminar, but 1 month these recorded lectures you can enjoy anywhere, anytime, and as much time as you want. We are going to start the digital library with my mobile app, which is also called as Ayurveda Academy. My YouTube channel is also Ayurveda Academy. Introduction, we have discussed electric circuit of the heart, waves of the ECG, normal ECG, chest leads, ECG of the first, second, third, AVR, AVF leads, sinus rhythm, what is that? Sinus bradycardia, less pulse rate, sinus tachycardia, left axis deviation, right axis deviation, left ventricular hypertrophy, right ventricular hypertrophy, right atrial hypertrophy, left atrial hypertrophy, myocardial infarction. What will be the ECG in the first day, on the third day, in the first week, in the third week, etc. Then angina pectoris, stress test, myocardial infarction, stress test, first degree heart block, Mobitz type 1 AV block, Mobitz type 2 AV block. These are all things that we have seen, third degree heart block, then left bundle branch block, right bundle branch block, hypercalcemia, hypocalcemia, hyperkalemia, hypokalemia, digoxin effect, and dextrocardia. My dear friends, I am very much thankful for your nice cooperation for my YouTube channel and also for my this mobile app, that is Ayurveda Academy. Please download this app and tell all your friends from first year to last year BMS and also to the different doctors. I would request that there are a lot of interesting things that are coming on through my app. I am going to take the webinar, a recorded webinar for the Ayurvedic dietetics. This is the upcoming or event. Then there will be the course for Ayurvedic Panchakarma also. Then there will be course for, you will get a digital library for medical, what you can say, the medicine in the general medical practice. Then how to treat according to Ayurveda. So Ayurvedic medical practice, Ayurveda in GP, this will be my workshop also through this particular app. So I request all of you to take the advantage of this interesting app and wish you all the best for your studies as well as for your medical practice. Thank you very much and take care and bye-bye.